welcome today Dr. Kimberly Corba. Dr. Corba is a board-certified family physician and the owner of Green Hills Direct Family Care in the Lehigh Valley area of Pennsylvania. In January of 2016, Dr. Corba successfully transitioned her 13-year-old independent insurance-based office to a direct primary care practice. She's an early innovator. She has been a national speaker and has testified publicly before the Pennsylvania Senate Banking and Insurance Committee on behalf of direct primary care. She is one of the founders and board of directors of Direct Primary Care Action, which is helping to move this movement of the direct primary care movement forward. She has written articles about direct primary care, has appeared in local, in state, and national publications. The movement wouldn't be where it is today or moving forward how it is without her and the other people that are part of the Direct Primary Care Action. She's a mentor to third-year medical students for the past 5 years and lectures about direct primary care to family medicine residents and medical schools throughout Pennsylvania. She's also an assistant clinical professor at USF Morsani College of Medicine. What I think is just so phenomenal about where she is right now, she formed a nonprofit group called the Pennsylvania Direct Primary Care Action Association. The mission of this organization is to increase awareness of DPC and educate about the benefits DPC brings to patients. They received a portion of the first annual Practice Innovation Grant, which is awarded by the Pennsylvania Medical Society in the fall of 2019. This is reaching out to public and private sectors and small businesses, primary care residencies, and medical schools across Pennsylvania. This is exciting to us, BRI, because we do have schools, we do have chapters in Pennsylvania. So our students, whether they're listening live or they're going to listen to this recorded, because they are studying for finals. Good job, guys. We are excited to be that Dr. Corba's, speaking to us today because this is directly impacting our chapters within Pennsylvania. I'm a big fan of Dr. Corba. She is helping what we're doing and moving us forward, and we need more people like her. So thank you for speaking with us today, and I am going to get myself off of the screen and give it to you.
Oh, well, thank you. That was quite an introduction. Thank you very much. When people read off everything that, any of us have accomplished, I'm not alone in this. And we have quite a team of advocates and movers and shakers put together. But when you hear the list of all the things that you do, it's amazing that we've done so much, pretty much in about 3 years, really a lot more accelerated in the past 2 years. Are the kiddos, I'm going to call them kiddos because I'm old enough to be their mother. Are they listening? Can they ask questions as we go along?
We have some that are live. We have more that are going to listen recorded because they're in finals. They're studying for finals.
Okay. Well, then I'm going to talk and just give a quick synopsis of what direct primary care is. And then, talk a little bit about where we're going, what we're looking for, how we're reaching out to the students. And, if any of them, if they're able to ask me questions at the end, I'm happy to answer them. So direct primary care has been around for almost a decade. I'm not in the pioneer phase. I'm more of the early innovator. There's a lot of doctors out there who've been doing a lot longer than I have. I was lucky enough to come in the early innovator phase, and have seen quite a amount of movement in direct primary care, and moving it forward as a new innovative model is becoming more accepted. People understand what it is. We don't have to explain it as much anymore. to potential patients who call, to people in the business community, et cetera. So it's really becoming a force and an option for patients and an option for physicians. It's not the answer to everything, but it's an option, and we're glad to be able to provide that option. So what direct primary care is, it's a subscription model for a set periodic fee, and it can be monthly, it could be quarterly, usually not annually, usually in shorter intervals than that, but for that set fee, you get a menu of services that are fully transparent, discussed up front, laid out in the patient agreement, and it's generally like joining Costco, joining a gym, joining Netflix. I was talking to my husband the other day, and we were reminiscing about our older teenage children and how much braces cost. Well, we paid a lump sum for our kids' orthodontic work, and that covered pretty much everything from the beginning to the end. And they popped a bracket or a wire, stuck them in the gum. I didn't have to pay for those visits to go for those repairs. So it's kind of similar to that, except this is we strive for long-term relationships with our patients. What we don't do is participate with insurance. So in my case, and some doctors are starting from scratch practices, some are converting existing practices, some are joining practices that are growing. We're seeing more and more doctors posting jobs looking to hire another physician in an already established DPC practice. My case is that I converted and I transitioned my private practice. I was still solo in 2015 when I made the decision to change my office to direct primary care. So I literally had the brick and mortar. I had the wall. You see my kids are 16 and 20 years old, and I still keep their baby pictures on my door. Because my son was 3 when I opened. He's now 20 and a sophomore in college. And I got pregnant the month after I opened in 2003 with my daughter, who is now 16. So this office has sentimental value to me too, because it grew with my family, and I was going to do anything I could to protect it. And you guys are probably too young to remember, but my generation lived through medicine changing from really being just about the doctor, especially on the primary care level. It changed from being just about the doctor and the patient to every Tom, Dick, and Harry being in the exam room with you. I was HIPAA rolled out when I had just finished residency. E&M coding had just rolled out when I finished my residency. And then it just got worse and worse from there with the insurance companies, with the quality data, the ACOs, et cetera, et cetera. So when I opened this practice in 2003, I knew I wanted to be a mom. My husband's a physician, and his schedule's a lot busier than mine. So I know I wanted to be there for my kids, and I knew I wanted to spend time with my patients. And so we got this 1,200 square feet. I only put 3 exam rooms in it because I knew I didn't want to get any bigger than this. I always wanted to keep it small. And I did have that kind of boutique-y practice way back in the beginning before it got more and more difficult to really focus on the patient. So I saw all the middlemen and the administrative layers just whittling away at my dream, my small, intimate family practice. We were all family, even my patients, taking care of whole families from grandmothers to grandkids. And I knew I had to do something to save it, because at the time, even though I wasn't employed by the local hospital system, I was part of their physician health network, which was slowly dissolving because all the doctors were selling their practices to the hospital. So there was hardly any independent doctors left in this physician health organization, this PHO. 5 years earlier, there was lots of independents, but I was one of the last women standing. And so I was allowed to participate with the hospital's quality program, which eventually turned into their ACO. And even though I wasn't owned by them, well, from 2010 to 2014, I was the #1 performing family physician's office out of over 100 family practices in our local network, most of the majority of them being owned by the hospital. So my data was great, And, I could do that because I could innovate, and things were small enough that we could really try to capture everything. There wasn't, in a small office, you can focus a little bit easier on jobs that need to get done. I think the bigger offices get, the more complicated it gets sometimes. So we were successful in capturing as much data as we could, and I had to capture every penny in reimbursement I could, because I saw my overhead going up and my reimbursement staying the same. So that margin was shrinking and shrinking. And, I knew there would come a point where those two lines would intersect, and I'd have to make a decision that I couldn't stay in business anymore. And I didn't want that to happen, because I said this is like the third child I never had. I was 36 when I opened the practice, and 37 when I had my daughter in the first year it was open. So, I didn't want to be that old of a mother, so I never had a third child. So the office was the third child. So I was going to protect this just like I would one of my kids, and put a lot of blood, sweat, and tears into this office. So I had seen a video by Dr. Josh Umber from Atlas MD in Wichita that somebody sent me in early 2015, and he was speaking at an AAFP conference. I think it was in 2014. And I remember I hadn't made the decision of what I was going to do with my office. I wasn't at that tipping point yet when I saw his video for the first time. But I remember listening to what he was describing, which was direct primary care model. And I remember thinking, that's too good to be true. That can't exist anymore. That's kind of the way I trained. I thought that went away a long time ago. And because I trained when we didn't have all of these distractions around us, administrative distractions that don't contribute to the care of the patient. So I watched the video a few times, and then I filed it away. I saved it somewhere, and every couple of months I'd come back to it and listen to it again. And it was so simple, it made sense. But it was so simple, you almost wonder how it could work in the world, in the medical world that exists right now, with all the regulations and the burdens. Well, when that tipping point came in the summer of 2015, and I knew I had to save my practice because the hospital was circling me like a vulture. They wanted to buy my office. I knew if they bought my practice that they would probably move me to another practice and my staff. And we had been together for over 10 years because that's what they do. And I didn't want that to happen. So I decided to transition. I did it in 3 months flat. And by January of 2016, I had opted out of Medicare and all the insurance carriers. Needless to say, the local hospital system was not happy. I found out later that they were not negotiating the same payer rates for me as they were for their own practices that were rating lower than me in quality data. And I had no control over that. There's no transparency. I wasn't included in any of that information. So here I was, working my butt off to get good quality data to capture every penny in reimbursements, and the hospital I'm doing it for is negotiating higher payer rates for their own practices that weren't producing the quality data I was. It was really a slap in the face. So they were not happy though when I opted out of insurance, because especially Medicare, because that means I couldn't participate with their programs anymore. And at that point, they told me they needed my data. And I mean, it's a huge hospital system here. And I said, well, my little piece of the pie, I'm a tiny little practice. You really needed my data that badly? And they said, yes. And I said, well, you should have thought about that a long time ago. So I didn't look back. We had 10% of our patients transitioned. I had 2,500 charts when I did this. I had 1,200 active patients who had been seen in the previous 2 years. 120 of them came with me. It was difficult, and even though the price for my services, my monthly medical service fee, is affordable, there were people who either didn't want to pay to stay, even though they were very happy with the practice, or they couldn't afford it, or, you know, there was various reasons. And saying goodbye to some of those patients was difficult. But I also had to save my practice, and I also had to save myself because I was starting to get burnt out. And this was at age 4, so 2015, I was, how old was I? 48. So that's really young to be getting burned out, although I understand it's happening earlier now. So anyway, I was the first one in the Lehigh Valley to do this, and I'm surrounded by big behemoth hospital systems here in the Northeast, in the eastern part of Pennsylvania. Philly's an hour south of us. Pittsburgh's on the other end. We got New York and New Jersey not far. We got Kiessling to the north. So we're kind of surrounded, and UPMC is starting to filter this way. We got Tower Health in Reading. We got Hershey down in Harrisburg. So just to be independent alone is, you know, being like a dinosaur, but never mind that I was stepping outside the boundaries and like being like fringe behavior by opting out of insurance. It was interesting, some of the comments I got. So that made me even more determined to make my practice work as DPC, and it did, and I'm happily full, and my patients are happy, and I'm back to spending a half an hour with them. So one of the other characteristics of direct primary care, in addition to this monthly membership fee, in my office, it ranges from $20 to $110 per month, depending on the age. It's age rated. And for that monthly membership fee, they get unlimited visits, unlimited telemedicine, whatever form of telemedicine they want. They get half-hour appointments. Everything's a half hour. I will go to an hour for a physical or a PAP. I will do a physical and a PAP in the same visit, which we couldn't do with insurance. Patients love that. If my elderly patients will have 10 things they want to discuss on their little list, they tell my girls up front, and I say, okay, that's not a half-hour, 3-month checkup. Give them an hour. We make house calls at no cost, especially right now during the COVID crisis. We don't want our elderly coming out. Sarah, my MA, has been drawing blood. I've been going and doing house calls. That's at no extra cost. Now that every practice is different. Some DPCs charge a little extra for house calls, but you know, you build your practice. There's no rules. There's some basic rules to follow, but as far as how you build your practice, you really respond to the economics in your area. You know, what people, you think they can afford for the value you're going to provide. Some areas charge more, and their overhead's higher. The Northeast is a little more expensive to you know, live and practice versus you know, somewhere out in the Midwest in a rural area. So Josh does have a saying that if you've seen one DPC practice, you've seen one DPC practice. I mean, we all follow generally the same rules, but you know, as far as the extra services, there's a little variation. Anyway, so the prolonged visits, I mean, it's amazing. My medical students love it because I tell them, stay in there as long as you want. The patients love it unless they have to go. And they go through their social history, they go through, you know, and it really helps them address the social determinants of health, which is a big buzzword. You know, they go through all their preventative medicine. And as the year goes on, because it's a longitudinal rotation with the medical school, with USF, so they come 1 day a week. And as the year goes on, they get it all done in a half an hour. But it's nice that they can get their feet wet, and I'm not on top of them to rush in the beginning, and they can make their way through the visit and the progress note. Our EHRs, the EHRs that DPC uses, we don't have, we can make macros, but we don't have templates or boxes we need to check. We all follow the guidelines: blood pressure management, diabetes, DEXA scans, colonoscopies, immunizations, you name it. And we do the appropriate social history, family history, et cetera, et cetera. But we don't have anybody babysitting us to make sure I'm keeping somebody's hemoglobin A1C below 7.5, because I'm going to do that because those are the recommendations, and that's the best care I'm going to give the patient. I don't need to swab every tonsillitis that comes in, which was one of the quality measures before I switched. I don't even know if they have that. So I mean, our progress notes are neat because you actually have to handwrite them out. So that's really new for the medical students, because when I was taught, we had to handwrite our soap notes. I really think there's something to having to write it out or type it rather than having it auto-populate, because it's like writing a story every time you see the patient. And you can get creative in your assessment and plan. Rule out gallbladder, right upper quadrant pain, rule out gallbladder, rule out pancreatitis, rule out nephrolithiasis. And then underneath that, you can write what you're ordering. And, I mean, I used to draw arrows on my progress notes. So the students really enjoy that part. It's a little bit of an adjustment for them in the beginning, but most of them by the end of the year say that it made their notes in the hospital and on their other rotations better by knowing how to handwrite a soap note from scratch. It is like writing a story. So we do the prolonged visits. The other thing we offer direct primary care is we negotiate deeply discounted wholesale prices for labs, imaging, and generic medications. There's one caveat with the generic medications, because we dispense in-house, most of us. There are 5 states that don't allow doctors to dispense in-house. Those states are working on that. But in Pennsylvania here, I'm allowed to dispense in-house. I'm not allowed to fill another doctor's prescriptions, because then I'm a pharmacy and I fall under the pharmacy's regulations. But dispensaries have different regulations in Pennsylvania. So I can dispense to my patients. And they're all generics. We order from a wholesaler, the same one that the big pharmacies order from. I only and it's all transparent. I mark up my pills 10% to cover bottles and labels, and it barely covers the labor. It's just a value-added benefit. It's not to make money. It's a value-added benefit, and it is hugely popular. We even have Medicare and Medicaid patients purchasing. Some of them have copays. Some of the Medicare plans have deductibles. They will purchase their meds through us rather than using their Medicaid or Medicare plan. I'll talk about all the insurances in a second, who it works with. And so we have the dispensary here, and then the imaging wing. One of the local hospital systems is actually really good at giving cash prices, but we also have a independent imaging center that is rock bottom. I can get a chest x-ray for $45. I can get an ultrasound, a pelvic ultrasound for $150, an abdominal ultrasound for $150. Cash pay for mammogram, $150 if they can't get it for free at the Department of Health. CAT scans, $350 to $400, MRIs around $500. So not only are we providing these value-added services, we're helping patients navigate the system. A laboratory CBC is $5. A hemoglobin A1C is like $6. It's insane. And you wonder if they can charge these low amounts, and that's LabCorp. That's, a major national laboratory company. If they can drop their prices that low and still make a profit, because they still have to make a profit off of those low prices. Where the heck are these inflated prices coming from when you see hospital bills, or when your insurance sends you the explanation of benefits? It's insane how much stuff is marked up when you see how low it can go. That was the most shocking thing for me when I transitioned. I didn't expect. I knew the prices were going to be lower, but I didn't realize how low. So medications are pennies on the dollar. I can get lisinopril, 10 or 20 milligrams for 2 cents a pill. So for my Medicare patient who's on 10 milligrams of lisinopril once a day, I can get them 90 days supply. You can do the math, $1.80. That's insane. Aspirin's a penny a pill. Metformin's cheap. They're all inexpensive. There are some that are a little on the higher side, but they're still cheaper than what you can get even for a cash price in the pharmacy. I will shop GoodRx with patients. Occasionally I find a better price with GoodRx, but I'll sit in the office and on the computer, and we look for the best prices with them. It's part of the time of the visit if we need to. So our three words, well, my three words that have caught on a little bit, especially in Pennsylvania, that describe direct primary care and what we're trying to provide for our patients and do for our patients is access, affordability, and attention. Those were the things that I felt I lost or were lost on my practice towards the end when I made the decision to transition it. So it's like the triple aim from DPC, access, attentiveness, and affordability. And some of the other ways we pay attention is through our telemedicine access. We're keeping people out of urgent care, which gets way overutilized. We're keeping people out of the ER. If my patients see a specialist and there's something a little off with their blood work, instead of saying you need to make an appointment to see your nephrologist, instead of taking up the nephrologist a valuable visit for somebody who could be sicker, I'll get on the phone with the patient in the office, speak to the nephrologist, and they'll either say, yes, I need to see her, or no, try this, and call me back in a few days and let me know how she's doing. I mean, that used to happen when I trained. And now I'm doing that again, and it's saving patients time, money. It's saving the specialist an unneeded visit because they're busy enough too. So that's another added benefit. You have questions? Let's do those first.
Okay, you were talking about DPC docs being able to distribute from your offices, and we have a question asking: is Washington one of the 5 states? If you know that.
It's dispensing. It's called dispensing.
Okay.
And I don't think I think Washington can dispense. Hold on, I'll look it up. I know Texas, believe it or not, Texas doctors cannot dispense.
Okay.
Yeah, Texas, where, they all love their freedom down there. They cannot dispense down there. New York, New Jersey, Massachusetts, Texas, and I forget the 5th one. I will find out in a second. I should know the 5th one. And despite the absence of that large value added benefit, DPC practices are growing in the states that can't dispense. It would be a huge bonus to them if they could dispense, and there's really no reason why they can't. But they're still growing without that. Okay, here we go. Without that benefit. It's on Phil Eskew's website too. There's a pretty good website out there called DPC Frontier, and it actually has a map of all the practices in the United States. The doctors that want to be on the map are on it. But Phil goes in, he's a lawyer and a doctor and an MBA, and he goes into a lot of detail on some of the legalities of direct primary care. It's I'm not being able to access it right. California? Maybe, no, I think they can dispense in California. I don't remember what the 5th one is off the top of my head, but you can Google it. Excuse me, or you can go to Phil's website, DPC Frontier. And along the border at the top, you'll see state by state, and it'll talk about it there.
Will Medicare recognize DPCs for the doctor visits and or prescriptions?
Oh, Medicare is like the bane of our existence. So one of our first trips as DPC Action. So let me talk about that first. DPC Action was formed almost like 2 years ago, a little less than 2 years ago, through Docs for Patient Care Foundation was our mother organization. Docs for Patient Care is not a membership organization. They survive on donations, but they put on the biggest direct primary care conference every year. It's in the fall. They've done 4 of them. We think this year is going to be virtual because of COVID. But underneath Docs for Patient Care, they formed this 503, I forget the tax designation. It's a nonprofit. It's a lobbying group. And there's 5 of us on the board. And we needed to represent independent DPCs in Washington, D.C. There was a lot of entities down there saying they were representing DPC and, not necessarily out to harm anybody, but the independents really had no voice. So that's me, Josh Umber, Dr. Lee Gross, Dr. Katarina Lindley, and Dr. Chad Savage. Chad's from Michigan, Katarina's from Texas, Lee's from Florida, Josh is from Kansas, and I'm from Pennsylvania. One of our first trips down there was to meet with Administrator Verma from CMS about Medicare and direct primary care. And we basically asked to, they have the Center for Medicare and Medicaid Innovation, CMMI, and they are allowed to try new projects. So we asked if CMMI would consider a pilot with 50 or 100 DPC practices around the country where they would give the Medicare patient the money to purchase their DPC services, whether it would be on a prepaid card or through a medical savings account, which is the Medicare version of a health savings account. Yes, they do exist. And yes, the government does fund them. Medicare patients don't even have to put their own money in those. They are around. So we gave her all these options, and the big hang up was from the administrator was that we weren't opted into Medicare anymore. And that matters to her. It doesn't matter to us because they can't follow our data. So our counter to that was the minute we start submitting this data, which is really not showing any usefulness, it's not saving that much money, it's not changing mortality and morbidity. The minute we start doing that again, it erodes into our relationship and our time with the patient and all the attention we're giving them for this very low monthly fee. So that is counterintuitive, and she wasn't biting too much. We asked her to instead watch downstream claims data, because we're all already taking care of Medicare patients. They come to us, they're finding us, they're paying out of pocket. Those Medicare patients, first of all, we're not billing per visit. We're already saving Medicare money, and they don't even know it. We're not billing per visit. We're not charging for telemedicine. We're keeping them out of the ER. We're decreasing rehospitalizations, decreasing specialist visits. Some of them aren't even putting their meds through their Medicare policy. They're purchasing and paying cash for our inexpensive generics, including over-the-counter stuff we get dirt cheap too. Same stuff you can buy in CVS. So we're already saving Medicare money. They don't have any way to track it. We could probably track it, but we just said for a year, 100 to 50 to 100 practices, just give us the ability, give those Medicare patients the ability to go to one of these practices, watch the downstream claims data. That's it. Don't make us don't ask us to opt back in, because we're not going to. That's like going from the frying pan into the fire again. So it's amazing how a crisis sometimes bubbles some good things to the top. Obviously, there's a lot of suffering out there, and a lot of people have lost their lives, and a lot of heartbreak going on, with this COVID. But one thing that it has really demonstrated is that direct primary care practices were positioned so well to manage this crisis. We've already been doing telemedicine. Our patients are used to it. There's no extra charge. We're not worried about billing. We didn't have to set up a new system. Our patients knew that's how they get us. And we were able to keep them out of the ER. We were able to innovate quickly and follow CMS, our CDC and FDA guidelines with the testing kits. And, we were pants on fire. Oh my God, I'm out of transfer medium. Okay, LabCorp says you can now use the con-tip Q-tips and 3 to 5 cc's of saline in an empty test tube with no medium and a screw top. Okay, we made a whole tray of them. And I was back, I had nasal swabs again. Whereas, the larger hospital systems, oh my God, we're out of, the transport medium, the special Q-tips. LabCorp said you can use these. you can innovate. So, not only were we well positioned to handle our patients, but we could innovate on the fly. So, I feel bad for our colleagues who are still taking insurance or employed situations, because I know it's been really hard on their practices, and some of them have had their salaries cut, some of them are furloughed. There's a lot of uncertainty out there, and I know they all work really hard. So, you know, maybe this will be part of the tide turning. And, you know, I'm not saying DPC is the answer for everything, but maybe it'll be the tide turning going back towards independent practice, some of which may still take insurance, some who might want to do a direct care model. But anyway, that's the story with them. And a lot of our patients with this COVID are Medicare patients. So it would be really neat to know across the country with, you know, nearly over 1,200 DPC practices, how much in savings we generated for Medicare, for CMS during this crisis. I don't think there's any way to know, but it's got to be a lot of money. So the administrator during the COVID, you know, crisis, all of a sudden she's loosening regulations left and right. Right now, you can see a telemedicine patient for the first time without ever laying a hand on them as a new patient. Well, that was a no-no before. All of a sudden, the reimbursement went up because before the reimbursement was really bad. And all of a sudden now you can practice across state lines. Oh my, you know, they were bringing doctors out of retirement, loosening those rules, graduating new medical students early. It was insane, the regulations that were just, you know, disappearing like this. And these are all the regulations that DPC, that, you know, we practice in that world without those regulations. And it took a crisis for CMS to realize they had to loosen some of the regulations to let the doctors care for these patients in this terrible worldwide crisis. So that's where we are. We'll see how things end up retrospectively after things calm down, hopefully, which is, you know, soon with COVID. But there has been discussion about the DPC practices and as far up as Washington and how we're doing through this whole thing. So I can't say we weren't nervous that patients, as they lost their jobs or they got furloughed, that they would cancel their memberships. To my knowledge, it hasn't happened very much at all. In fact, a lot of us are getting calls from new patients who want to become part of the practice. But we were holding our breath. We were worried with the unemployment rate going up so high, you know, what would happen to our patients. And some practices were actually giving, and this is the other thing we can do. We don't have to charge anybody. You could scholarship a patient for a month if you want. You can exchange services. The old barter system. So there were some practices out there, you know, giving patients breaks who lost their jobs, and you're able to do that. And DPC, you can't do that with the insurance plans when you're in contract with the insurance plans. So
I know it's a big thing that we're talking about at BRI. We just recently, with one of our students, did something with Freedom Works talking about just that. We were talking about regulations that are in place that obviously just don't need to be there anymore or need to be changed, that we're seeing because of the pandemic, that clearly we need to take a look at going back into the new reality. And DPC is one of those things. Clearly it's been working. It's been working for these 1,200 practices. So what is that going to look like going back in? You know, what does CMS need to do in changing these regulations for good? Because we have something that makes sense and that is working. You know, how do we need to keep this moving forward? We have this new stimulus bill that's looking at transparency. That's, you know, it has things about transparency. It has things about telemedicine. And that's good. It's good that we're taking a look at that now. But what does that mean in a year? How can we keep this? And I know that DPC Action and our wonderful coalition at Free to Care are doing things to make sure that we're keeping this going and that we're keeping this conversation going, so that you know, it's not just the now, it's the tomorrow. I have another question from one of our BRI alumni texted me. He is now at Vanderbilt Family Practice, and he is, or family medicine resident. He said he wishes that he would have spoken to you when he was still in medical school, which was great. He said that it seems that you got your practice up and running as a DPC practice very quickly. And he wonders, it seemed quick compared to other things he heard, and he's wondering how you got those partnerships with private, with other groups done so quickly, because it seems the timeline was rapid.
Well, I'm 4.5 years into this. I'm going to be completely transparent. The first year was not easy. And the people who are listening now are going to have it a little easier because people are more educated about the model. And so the people who, don't appreciate it or might be bad players or try to take advantage of it, which I had a lot of that the first year, they're not so apt to do that anymore because this is becoming more of an accepted model. It's becoming more people are educated and aware of it. That first year, because the model, first of all, I was the only one here in the Lehigh Valley, population 800,000 people, to do this. I grew up here. I went to high school here. I went to college here. My dad's a businessman here. My husband's a physician. They were like, and so, when I did this, all eyes were on me. I was under a lot of pressure, and then obviously giving the heave-ho to the hospital didn't help. But I was under a lot of pressure. So, and, my practice is like a family, and I treat my patients like I would do, like what I would do for my family. When I had patients signing up that first year who would come for a month or two, get their physical, get 3 months worth of refills, and then quit. I had people not pay. They'd come in and get everything, and they'd not pay. And we've all had that happen. I think it happened a lot more in my situation because it was so early in the development of the model on a national scale and a regional scale, and because I was the first one in the Valley. People, and it was inexpensive. I did raise my prices once in 4.5 years. I think my prices were, and I had to price myself low to get people in the door. But there's that thinking that, something's priced too low, people look at it as cheap. So there's a fine line in that marketing or the business planning where, are you too inexpensive? Or, you don't want to be too expensive either. So you've got to find that sweet spot, and that's all it's regionally based. But I felt because I was the first one, I was really taking a leap by converting a successful practice into DPC, which I knew would be successful. I did have to price myself a little low. I think that attracted people who thought they could really game me a little bit. Not everybody did, but it was enough that there were a few gut punches along the way. And, I was like, gosh, I'm almost middle-aged. I take good care of my patients. Why are people doing this? This is affordable health care. Why are they quitting? Why are they not paying their bills? And, but that's human nature. So, you got to take those, when a new model's emerging, you've got to take the hits along the way. And, you'll hear similar stories from other early innovators and the pioneers, and you work those kinks out. So I made a tighter patient contract. I discuss everything with them up front. We make it very clear that we have to pay for stuff as it goes out the door. We appreciate if they, if they want to leave, at least they pay their balance. And now people are I haven't had any bad players in about, knock on wood, in about 3 years now. So it wasn't that easy in that first year, probably almost a year and a half. And I didn't fill right away. My goal is 400 patients. That's where I want to be. I have a lot of chronic illness that comes in here. I have healthy families, but my patient population is a lot of chronic illness they require a lot of follow-up, a lot of attention, a lot of coordination of care. So I would have liked 600, but I came down to 400. And there are practices out there that have 600 to 800 patients, and they're, a lot of them have young, healthy families that, aren't requiring that 3-month checkups, for their chronic illnesses, and then sick visits in between, and lots of blood work and lots of specialists. And So I changed my goal to 400 patients, and I'm very happy where I am. There is a constant churn. It's interesting though, since January, I haven't had any churn. First time in 4.5 years. We're kind of trying to figure this out. We don't know if it's the pandemic, or if it's that the model is becoming solidified, or a combination of both. But the churn has definitely slowed down in the past 5 months. It's crazy. I've had maybe 2 people leave, and I've had a whole bunch sign up. So, people may be really discovering the value of good primary care, because let's face it, we are the boots on the ground. None of those specialists want to deal with what we deal with. And, we're front line, and if we can do our job, it's going to save the whole healthcare system a lot of money. And we are the epitome. Direct primary care is really the living, breathing example of price transparency, patient-centric care, getting rid of the PBMs, and well, we deal with a GPO through our wholesaler for our meds, but I mean, our meds are pretty cheap. But getting rid of the PBMs and the middlemen, we don't deal with a lot of pre-auths, and occasional pre-authorization, hardly any. We don't deal with all the rigors of the clunky EHRs. We are providing good care, still writing great progress notes, hitting all the preventative issues. So, all of those other advocacy things that we all support each other through Free to Care organization, and all the advocacy groups are there, and we all support each other. But, direct primary care has it all kind of bundled up in a nice little package. Practices now are growing a little faster because the model's more accepted. So if you're coming out of Vanderbilt and you want to open a direct primary care practice, there are more and more young doctors looking to do that right out of residency, or to join a practice that's growing. Because it's more accepted and there's more education and awareness out there, these practices are not having the stumbling blocks we did a couple of years ago. One of our first tasks with DPC Action was to kill a bill, and I never thought that would be on my bucket list. We had a lobbying group in Washington that has been there for a long time and has been a big supporter of direct primary care, bring a bill to the table to Ways and Means Committee in June of 2018. We were not aware of it. We got called literally 24 hours before it was going to go to be marked up in Ways and Means Committee, before it was to go out to the House floor for a vote. We read the bill, and it was horrendous. It put a cap on what DPC offices can charge. It would be the first piece of legislation to cap what patients can pay and what doctors can charge. No other legislation exists like that. With their HSA accounts. This is about HSAs paying for DPC. So this was capping how much people could pay for their direct primary care services with their own personal money in their HSA account. Meanwhile, you can go out and buy your very expensive prescription designer sunglasses with no cap on that, right? That was one issue. The second issue is it really didn't clear up some tax. There's some issues with Treasury, with the tax code, with HSAs. It didn't really clear up the fact that we are not an insurance plan, that we're a membership model. So that language was very foggy, which leaves it open for interpretation down the road if that bill was to pass. It also excluded specialists from doing any kind of direct care model. And there are specialists doing it. It only included primary care. The original bill actually excluded women's care from being paid by an HSA in a direct care practice, which was insane because that's preventative medicine. It also would not, some offices bundle some of their generics in with their membership, like 10 different, they'll just do that they just design their DPC office that way. Most of us don't charge for joint injections. We don't charge for the steroid or the lidocaine. We don't charge for any medication put in to do a suture. I don't charge for nebulizers, the albuterol. I don't charge for any of that's all included. EKGs are free. But the medications and prescriptions that we might use in the office or somebody might bundle into a membership, that was excluded in this bill from being allowed to be bundled in with a membership fee. Any prescription drugs, no matter how you're delivering them to the patient, which was insane. We were so dumbfounded of why are you going to add regulations to a model that's working and is the most affordable thing out there for patients right now. So, the only answer to that question is obviously the special interests who want to put a lid on us and want to, and are not really behind independent practices doing the best for their patients. So we really, within 24 hours, I don't think any of us slept for 24 to 36 hours. We rustled up such a contingency of supporters that and created so much noise in Washington that the bill died. Then the bill resurfaced again with a new name and a few little changes, but still overall not a great bill. I don't say we killed it this summer, we maimed it maybe, but it keeps popping up, and it popped up again in December, and then they tried to fit it into the first COVID relief bill, and there was a lot of hoopla about that, so they took it out. So it's still out there. Now, in response to that bad legislation, and this isn't a bipartisan, DPC's bipartisan, so I want to make that clear. But the Republicans, the GOP, are moving a little bit faster on regulatory change and on legislative change. I wish we would have the same activity on the from the Democrats too. The bad bill was sponsored, unfortunately, by a Democrat because it shouldn't be that way. It's nonpartisan. Anyway, Chip Roy and Ted Cruz Senator Cruz wrote the first bill, and Congressman Roy mirrored Senator Cruz's bill. And it's a great bill. They're both great bills. They're overreaching HSA reform. DPC is one little part of that. They are taking health savings accounts and making them available to all Americans. Right now, you can only purchase an HSA account if it's tied to certain insurance products, one of which is a high deductible health plan. So, people, left-leaning politicians tend to look at HSAs as things that rich people have. Well, I don't know many people who can barely even afford their high deductible health plan, never mind putting money into an HSA account. So that dialogue has to change, and the way that that's looked at has to change. Health savings accounts are like opening a bank account, but you get to put tax-free money in it. It comes out of your paycheck tax-free, it grows tax-free with interest, and you withdraw it without paying tax on the growth. It's triple tax-free. There's nothing else that exists like that in this country. And every American should have the ability to put $10 a month, $20 a month, $100 a month, whatever they can afford up to the maximum in this tax-free, triple tax-free account, and use that savings account to pay for medical expenses. So these two bills from Senator Cruz and Congressman Roy separate HSAs away from having to be tied to these insurance plans, make it available to Medicaid patients, Medicare patients, patients with no insurance, patients with health sharing plans, patients with short-term limited duration or indemnity plans. I know a lot of this is insurance mumbo jumbo, but just know that the HSAs would be available to anybody, no matter what coverage they have or if they even have any, because there's a lot of people who are uninsured out there. Think about it. The people who are uninsured and can't afford anything, why shouldn't they be able to put a little tax-free money in a savings account to pay for their medical services? That would only make sense. And in the economic recovery, we're all going to be licking our wounds for a while after this COVID thing, especially the small employers. In the recovery, why wouldn't you make it as easy as possible and as affordable as possible for everybody by having these HSAs available? So that's a big kind of oversight on those two bills, which are very good. And there's a section in there about direct primary care. It gets the tax code right correctly. We are not insurance. It does not limit it to just primary care. It does not limit our ability to dispense generics. It does not put a cap on what patients can pay with their HSA. So it's a clean bill, and we're hoping that it gets some traction. Because it mirrors the price transparency. If people have their own money, they're going to shop the best price, just like we do when we go food shopping or go to Costco or shop online. We look for the best price. Amazon. People have their own money to spend. They're going to look for the best quality at the best price. And so it parallels the transparency push. So that's where we are with legislation. And I didn't know anything about politics in med school. I could have cared less. But you guys really need to know about it because it's much more of a factor in your future. You need to start watch things if you're not watching them already, no matter how painful it is to watch it.
That's really helpful. I mean, I think it's really important to get the information from people who are doing things and are active in this community. One of the things that BRI is doing is helping to teach the students about how to be advocates. We are an education organization, but we're helping to teach the students how to advocate if that's what they choose to do. We're partnering with the Leadership Institute to run a 3-part series on advocacy starting next month.
Oh, that's awesome.
Because
I wish we had that.
Yeah, I mean, that way they can get involved with DPC action. They can get involved in what we're doing with Free to Care. They can get involved with all of these things if that's what they choose to do. Create, that once you get to your MD or DO after your name, you become this much more powerful in knowing what to do with your name. And knowing how to advocate, whether it's as a student or afterwards, is just so important. So we're really excited to be doing this with Leadership Institute. It's going to be a 3-part series throughout the month of June, and just virtually, obviously, but it's exciting. And this information that you're providing, DPC Action, Free to Care, all of these great organizations and great partnerships is just so important for the students to get involved in, the students of today, but also those students of tomorrow that as BRI grows, we need to push that information and keep pushing the great information that you're providing. So
if I can add one more thing,
sure.
The medical students, this is politics and the medical industrial complex, Free to Care, all the different advocacy groups, they all refer to it is the medical industrial complex, has affected the delivery of healthcare and how medicine is in this country. And, the young students, they have a chance to make a difference, and it's going to affect them, it's going to affect their careers. So it's really important, and I'm so glad to hear BRI is doing this. It's really important for them to get involved and, not to sit by passively and just say, thank you, sir, may I have another? Because without us, without the doctors, there is no medical system. I don't think the students know how powerful they are as the future of medicine. And, they could all argue over their middleman fees and their rebates as much as they want, but if they don't have doctors writing the prescriptions, it doesn't matter.
And that's what, this information, knowing that there is more to their education than what they are getting currently in school, is what we're about, and why it's so important that doctors, current physicians that understand that better than anybody, help us to provide them that information. And
BRI, you guys are such a strong supporting organization. We didn't have that in med school, and it can be pretty scary out there sometimes when you don't have people backing you up. And, with BRI and all the other organizations, Free to Care, David Ballard and Marion Mass from Practicing Physicians of America, and it's really quite a bunch.
Yeah, and we're only getting stronger, and I feel like that is what's so exciting about what we're doing is throughout, even in the past couple of years, I feel like this network is getting stronger and stronger and more vocal. You explained what the genesis of DPC Action is. It's not a long, this hasn't been going on that long.
No.
We fought against Obamacare, but things have changed even more drastically since then. And it's, this pandemic has enforced just louder and louder what we need to do and how loud we need to be. And the education that we can all provide the next generation of doctors and healthcare workers is just so vital right now. So we thank you for your time. And if anybody has questions for Dr. Corba, you can reach out to me at rebecca@benjaminrushinstitute.org, and I will be happy to provide contact information. This is going to be being recorded. We will provide the link up on our website and our Facebook page. So for those of you streaming, we will provide it. Thank you so much. If you are a physician or a policy expert that would like to join us, please get in contact with me. Thank you so much.
Can I add one thing really quick?
Absolutely.
Everybody should tune in to Dr. Singleton next week. She taught me how to lobby and how to advocate. I spent 3 days with her 3 years ago, and she taught me everything I know, and she is a wealth of information. You're gonna love hearing her.
I'm a huge fan of hers. I was kind of out when I contacted her. I used to help run a gigantic grassroots women's movement, and I told her that, and I was kind of having my fangirl moment. So, yeah, it happened. So
she's my hero. If I can grow up to be like Marilyn Singleton, then I'm good.
We're all good. So,
yeah.
looking forward to I'm looking forward to meeting you in person. Maybe
you too. Yes.
Someday that'll happen. So
yes, hopefully.
So thank you so much, and thank you all for joining us.
Thanks for having me. Good luck, everybody.
Thanks.